Hi friends, I'm Dr. Natalie Crawford. I'm a board certified OBGYN and REI. I'm a fertility doctor, and every day I talk about fertility, your hormones, your ovaries, your eggs, and this channel exists so that you can learn about it too. So please subscribe and follow along. Today I am talking about things you commonly hear at the OBGYN office or the fertility doctor, specifically the fertility doctor when it comes to your ultrasound. So what does your doctor mean? Are you really running out of eggs? What is that cyst? Because we say things and I know it's just us trying to make small talk or using normal rhetoric, and it leaves you with a lot of questions. So I'm gonna go over a few of the top ones right here so we can dive into them. All right, so the first thing that I often hear patients be very confused about that we say is they're like, oh, your uterus is tilted, or oh, your uterus is retroverted, anteverted, oh, you have a tilted uterus. This throws patients through loops all the time, and the reality is we're just commenting on it because often it's taking us a little bit longer to find it. We're just making small talk. We can't help but comment when we see it this way. What that means is that the uterus is naturally a little more considered like neutral in your body. If we want to think about it, it is attached to the cervix, and if you're standing up, the cervix, is anchored in your pelvis, and here is the uterus. And the uterus can be tilted backwards so that it's touching, like the top of it's tilted towards your back, and the cervix is more touching towards the anterior, your belly. It can be tilted anteverted, which is more common, where the uterus is tilted upward, like towards your stomach, and your cervix is tilted down. This can be pathologic, but it can also just be normal variant, meaning you have red hair, you have blonde hair, you have brown hair, we don't worry about it. Does not decrease your chance of getting pregnant, does not cause infertility for having a tilted uterus. Now, the big asterisk is, why do you have a tilted uterus? Because sometimes we see that your uterus is tilted and the etiology potentially can make a difference. So the biggest one is going to be a retroverted uterus where the top of the uterus is pointed backwards in somebody who potentially has abdominal scar tissue. Endometriosis is going to be a big player here, because if the uterus is in that position and stuck, is it a sign there could be endometriosis? And we know endo does cause infertility, and I have a big video on that. The other thing, if it's anteverted, so if it's really attached kind of towards that abdominal wall, did you have a prior C-section? Could it be stuck that way? Now, C-section alone does not cause infertility. I had a C-section with my first child and tons of infertility getting pregnant with her, and my second, not, but I'd already had a C-section and everything was fine. So C-sections do not cause infertility, but sometimes they can. Like, so if your uterus didn't heal all the way or you have an isthmocele, that potentially could be something contributing. And there are often some signs or ultrasound findings of that. So that would be something else that would be noted. So that would be if you have a very anteverted uterus or anterior uterus or a tilt, and you have a history of a prior C-section, especially if you have any weird discharge, spotting, bleeding patterns, pregnancy losses, that's something to talk about your doctor, like, oh, did my C-section scar heal all the way? The next thing is talking about endometriosis. So there's this huge misconception, and I hear patients say every day, oh, I don't have endometriosis because I had an ultrasound and my doctor didn't see it. Endometriosis is not diagnosed on ultrasound most of the time. Endometriosis is a surgical diagnosis. Endometriosis is where you have implants of endometrium, endometrial-like tissue, which is the lining of the uterus, that grow outside the uterus in what we call the peritoneal cavity. These implants are hormonally sensitive. They grow and they change based on what's going on in your body. But what happens is they can cause inflammation, it's on the autoimmune spectrum, and they can cause scarring. But you can't see that. Most of the time, the ultrasound is perfectly normal. The uterus is not stuck in any position. The uterus looks fine. Endometriosis, beyond having the endometrium word, is not a disease inside the uterus. The only exception here is if you potentially have an endometrioma. An endometrioma is where endometriosis gets inside a follicle. So remember, as that egg grows, the follicle grows, it ruptures to allow the egg out when you ovulate, reforms and becomes a corpus luteum, which gets tons of blood supply as it pumps out that progesterone for the luteal phase. Well, if you have endometriosis and some little endometriosis swings in and gets in there, it loves the blood supply of that corpus luteum and it just grows and grows in that environment. So you can see an endometrioma on ultrasound. It can also look very similar to a corpus luteum. So if it's a very first time look, your doctor may say, I see a cyst, the big 4-letter word cyst. It might be an endometriosis cyst. It might be a normal, functional, ovulatory cyst. I don't know. We're going to need to repeat the ultrasound and see what happens. Endometriosis cysts do not go away unless you have surgery. Corpus luteums go away when you're not pregnant that month. So seeing what happens can help differentiate. Other signs that can be suggestive of endometriosis can be, as we said, like a very retroverted uterus or having your ovaries look very stuck in places, like distorted anatomy. But again, not having that doesn't mean you don't have endo. Most endo doesn't have extreme anatomical changes. That's when you get into very late stage disease. So you don't know, or endometriosis has not been ruled out just because you didn't see it on your ultrasound. The other thing is the cyst. Y'all, like a whole video on cysts. I think this is such a fault of how we have counseled patients. A cyst is a fluid-filled structure. And when you ovulate, if you are not on birth control and you are living your natural life, you should have a cyst most days of the month if you have an ultrasound, a CT scan, an MRI. And that is because the only time you really shouldn't is right when you're having your period, because a follicle is a cyst. A corpus luteum is a cyst. Those are considered functional cysts. What happens is that group of eggs comes out of the vault and a follicle starts growing. The follicle gets pretty big. It can get to 2 to 3 centimeters. It's filled with fluid. It's a cyst. It ovulates. The fluid comes out. The egg comes out. It reforms and becomes the corpus luteum. As I said, it's kind of bloody, fatty, making different types of hormones, and it looks different. So corpus luteum and a follicular cyst or a follicle look different, but they're both cysts. And that corpus luteum lives. If you get pregnant, it keeps living for the first part of pregnancy. So you should even have a cyst in early pregnancy. And if you're not pregnant, it then dies, it goes away, your progesterone drops and you get a period. But so you should have a cyst most days of the month. And that's a big misconception, or somebody thinks that's a big problem that they had a cyst. On the offset, there's other cysts that can be problematic. So especially cysts that do not change or do not go away or get bigger. These functional cysts, these cysts that are normal within your cycle, they change. Follicle grows, corpus luteum goes away. Next month, something different. So if you have a cyst that is growing, changing, it's very common to do follow-up for a cyst to kind of see if it's changing or going away or getting worse, then it's definitely something you want to follow up. Ovarian cancer is extremely rare in younger patients. It's so hard to diagnose though. So those cysts typically look very different. I have diagnosed it on random ultrasound in somebody with no symptoms. It looks different. But if you have a cyst, don't automatically jump to this is terrible. It's very important to tell the person like where you are in your cycle and could it be a functional cyst or not? And is this something you really need follow up on? How does it look? All right, and then the other one is your antral follicle count. If you're coming to the fertility doctor, we'll do a count of how many eggs we see. And I have had so many patients believe that this is all the eggs they ever have. So I do a count, I see 7 eggs, I say this is 7. We'll talk about if that's normal or not based on your age and your AMH. And then I will get on a follow-up call and a patient will say, well, gosh, I only have 7 eggs left, so I'm going to be in menopause in 7 months. So there's no use in me doing anything. And I'm just like, oh, we have failed you. Remember that your antral follicle count, or the follicles that we can see outside the vault and the ovary, this is a this month representation. So you're born with all the eggs you're ever going to have in that vault. Every month, a group of eggs comes out of the vault. From the group, one egg is chosen to ovulate, the rest of them die. Next month, another group. When we do IVF, when we do egg freezing, our goal is to try to get all the eggs growing and ovulating so that you have a higher chance. That's how we're increasing the odds. But that month, those eggs are going to go away. The eggs that are out of the vault, they're dunesies. Those 7 eggs, they're gone. But next month, you're going to have a whole nother group. The size of the eggs remaining is proportional to how many come out. So if you have more eggs left, you have more coming out every month. And if you have less eggs left, you have less coming out every month. There's also month-to-month variability, meaning we can see a 30% swing. So if you come in and I see 7, I don't know if that's your average, if that's your very best month, or that's your worst month, where you fall. That's why the AMH blood test, which is a hormone made from the cells that surround these follicles, is also helpful in interpreting your ovarian reserve. Other important facts: having a low egg count doesn't cause infertility. Having a low AMH doesn't cause bad egg quality. So yes, it might shorten your time. Yes, it's going to mean you're going to get less eggs per an IVF or an egg-free cycle. So you might need more cycles. You might have a lower chance of success per cycle. It's why I really hate per cycle metrics for clinics, because each patient is so individual. But it doesn't mean that you're almost out or that that causes infertility. But you might do something different. You might be more aggressive. You might bank eggs or embryos. So that data is very, very important. And then things like birth control pills or hormonal contraception in general, or pregnancy, can suppress AMH and can suppress your follicle count. It's not that they're not there. The easiest way to think about it is that they still come out of the vault during those times. They just, if they don't see FSH for a really long time, they're not as big, they can't be seen on ultrasound, and they don't make as much AMH. Now, when you're more postpartum or when you have stopped the contraception for a month or so, you will see a resumption to normal. So if you come in and you get a follicle count and it's very low, or your AMH is low, and you're on hormonal contraception or immediately postpartum or immediately off like a big loss, like where you were pregnant for a while, it is worth considering, should you wait and repeat it versus getting started in testing or treatment. Kind of depends on the full picture. But just know that doesn't mean that those things, pregnancy or hormonal contraception, hurt your egg count. It's just a small suppression that it's harder to see at that moment, and you have to kind of give your body some time so that the follicles perk up and can be seen on ultrasound. And then the last thing to just say is that you typically cannot see fallopian tubes on regular vaginal ultrasound. So I also have patients say, yeah, my tubes are open, my ultrasound was normal. That test is not evaluating the tubes unless we do what's called a FemView or a bubble test, where we put water and air through the fallopian tubes on the ultrasound. Or you have like an X-ray test, and HSG is the classic test to evaluate the fallopian tubes. Only exception here is that if you have a blocked and dilated tube, sometimes we can see those on ultrasound, and that's called a hydrosalpinx. So just because we can't see them does not mean they are normal, but there are chances where we can, and if we do see them, it's definitely abnormal. All right, well, I hope this helped you understand, I guess, a few common ultrasound myths, things we say that need further explanation, and just helping you understand what we can and can't do when we are doing an ultrasound to evaluate your fertility. All right, friends, thanks so much for being here. As always, you can get more information on the As a Woman podcast or over on Instagram at Natalie Crawford MD. We would love it if you want to ask other questions, things your doctor says, questions you have about things that may be occurring in the clinic or on ultrasound, so that we can answer those for you. Bye, friends.